Now, neuro exam is a bit prop heavy. So a lot of what we're going to do is also introduce the props as well as go through the exam. So what are the 4 aspects of a neurological exam?
Inspection.
No. Mental status exam.
Neuro.
Well, they're all neuro.
Oh.
Cranial nerves. Sensory and motor. So we've already done mental status exam. We did that during class, and you guys passed with flying colors except for the abstraction part. So what we're going to do right now is we're just going to focus on cranial nerves, sensory, and motor function. All right, so out of the cranial nerves, first one is olfactory, and we're not going to assess that one. Although if you were going to, you'd have your patient close their eyes and hold something that's smelly underneath their nose. So things you could use in a hospital that are smelling. Alcohol swabs and coffee. Those are probably the biggest 2 smells that you would want to have a patient sniff. Even if you don't like the patient, don't use nasty smells on them. All right. So the next one is the next nerve is cranial nerve number 2, the optic nerve. So for optic nerve, what we're going to do is we're going to have the patient read a visual chart. A small one is called either a Rosenbaum or Jaeger card, and the big one is called the Snellen chart. So, Snellen. So, card is held in good light 14 inches from eye. Ideally, you would measure the distance, but usually what happens is people just guesstimate. So read the smallest line you can read.
The numbers 428739.
All right, and it looks like 2020. So when we do eye in a couple days from now, we'll tell you how to interpret that 2020. But for now, you just look at the side 2020. Also, you'll notice on your card that sometimes it has little letter E's that face different ways. That's for kids who can't read letters or numbers yet. They can point the direction that it's pointing. So you take your hand and you point the same way it's pointing. All right, so that's the optic nerve. Now, next we have which nerves? Oculomotor, trochlear, and then we're going to skip 5 and go directly to abducent. So we're going to do all of those in the next couple tests. So we're going to get a light source, and your light source can be either the otoscope or ophthalmoscope, but it could also be a pen light. You're going to need to get a pen light for school. The problem with these little cheap ones is that when they say disposable, they really mean they don't work when you buy them. So I'd recommend if you get a pen light to get a decent quality, like a mini mag light or something like that. It'll last a lot longer than these little
You can't replace the batteries on those, right?
These you can't replace the battery. You just have to toss them. And tossing batteries is not good for the environment. So really, you have to recycle it. Save yourself trouble. Just get a good one to begin with. All right, so what we're going to do is we're going to first look at our patient in the eyes. And what are we going to look at? Pupils E, perla. P is pupils, E is equal. So are they equal in size, and are they round? Then we're going to shine the light on the eyes and see if they contract. So do the pupils constrict when you shine the light? All right, so that is called RL, reactive to light. Then the next thing we're going to do is accommodation. So I want you to focus on my finger. And now keep focusing, keep focusing. And as you bring the finger in closer, you should see the eyes come to the center, and then you should see the pupils constrict. The pupils constricting is called accommodation. The pupils moving, or the eyes moving to the center is called convergence. Which one are we interested in here? Accommodation. So we're interested in the eyes constricting as you move that in. So again, observe the eyes, pupils equal round, reactive to light. Focus on my finger, and keep focusing, and accommodation. The other way you can do accommodation is focus on my finger, focus up close. Some people will do better with one or the other. Sometimes it'll make a person dizzy when you go, they're like, all right, so that's perla. The next step is what we call extraocular movements, or EOMs. So what you're going to do is you're going to tell the patient, don't move your head, just follow my finger with your eyes. Move to the side, and then you're going to make an H, a big H in the air. coming back to the center, to the other side, and another big H. And then back to the center. Now, a couple key things. First one is don't move too fast. If you go, patient's going to go, woo, dizzy. Some people will actually make them so dizzy that they want to fall over. The other thing is you want to make sure that you get the eyes all the way to the corners of the eye before you move up and down. So, follow my finger again. If you only go to here and then go up, you haven't really tested the full movement of the eye. So make sure the eye moves all the way to the corners, then up, then down, back across all the way to the edge of the eye, back up and down. All right? And you also want to make sure you're standing directly in front of the patient as you do that. Any questions about the external ocular movements? All right, so you got cranial nerve 2, cranial nerve 3, 4, and 6. What's next? Trigeminal. Now for trigeminal, you're going to get a Q-tip or a piece of cotton. You're going to ask the patient to close their eyes. And what you can do is you're going to say, tell me where you felt a touch on your face.
Did I tell you?
Yeah.
My
Or
forehead.
you can point.
Right.
Okay. Okay, so remember, trigeminal has 3 roots, and you've got to test all 3 roots, both sides of the face. In addition to the feeling on the face, you can also do the masseter. So you can palpate the masseter and bite down, and you can feel the strength of the masseter. You don't want to put your hand in the mouth and clamp down. That would be bad.
Wait, what did you say?
So put your hands over the masseter and ask her to bite down. And you can also do the corneal reflex test. And to do that, you'd get a little wisp of cotton, and you ask her to look straight forward, and you put it into her eye, and when she blinks, that's positive corneal reflex. So we're not going to do that to each other. So the 2 tests that we're going to do, we do the, tell me where you feel this on your face, and, bite down. Let me feel the masseter. That's cranial nerve number 5. So next is cranial nerve number 7. So the facial nerve. So what we're going to do is smile and frown. Puff out your cheeks. And don't let me push them in. And close your eyes really tight. Don't let me pull them open. So that is the facial nerve. All right, what's next? Cranial nerve number 8, the vestibulocochlear. So two things we can do. The one is just gross hearing. So what we're going to do is we're going to plug one of her ears by pushing on the tragus, and we're going to cover our mouth so she can't lip read, if she's good at lip reading, and you're going to whisper a word.
Hospital.
Hospital. Then come around to the other side. School.
School?
School. Right, so turn your head this way. So this forward part right here, this is called the tragus. You're going to press in on the tragus, and it's going to keep her from hearing out of that ear. So that way, you're testing each ear individually. And you can test them both at the same time, but you don't get as much information by doing that. The next thing we're going to do is we're going to do tuning fork tests. Now, on your head-to-toe exam, you're not required to do the tuning fork tests, but you do need to know what they are. So this is a tuning fork test. It's a 512, which means it vibrates at 512 hertz, 512 times per second. Now, this is the proper one for doing these 2 tests, one called Weber, the other called Rin. So Weber test, you're going to bonk it, hold it on the top of her head, and do you hear anything? Probably not.
No. I think so.
And where do you hear it? It's gone now.
I don't know.
Yeah. These are really cheap. They don't work very well. So even though you're not supposed to use them, I'm going to use a different one, because this one you'll feel a lot easier.
Yeah.
Where do you hear it?
It's like a buzzing everywhere.
Just like kind of. So the correct thing is everywhere or the top of my head, or both ears. What shouldn't happen is it should not be louder in one ear or the other. If it's louder in one ear or the other, that's called a positive Weber test. If it's heard in both ears equally, or the top of the head, or everywhere, that's called a negative Weber test. All right, now turn your head this way. All right, now what is this bone right here called? Right behind the ear? The mastoid. So what we're going to do now is we're going to bonk it again. and we're going to place it on the mastoid. Do you hear that?
Mm-hmm.
So what we're going to do is we're going to wait until she can't hear it anymore. Okay, and then we're going to place it here. Do you hear that?
Yeah.
Okay, so what that means is she was hearing through the bone, through the mastoid. She did not hear it as long, or as, it was softer. She couldn't hear it anymore. We took it away, now put it next to her ear. Now it's going through air, and she could hear it again. So what we're doing is we're doing bone conduction versus air conduction. This is the RIN test, R-I-N-N-E. So, if, when she can no longer hear it on the mastoid, you take it away, put it on the ear, or in the air, and she can hear it again, that's normal. That's called a negative RIN test. If you take it off and she can't hear it at all, that's called a positive RIN test and is abnormal. So have you ever, you've been singing and you can't really hear yourself well, so you put your finger in your ear and now it sounds different, you can hear yourself singing better? Good. Say la la la. Now put your finger in your ear and say la la la. Does it sound different? Yes, by plugging your ear, you're no longer having air conduction, you're using bone conduction. So that's what we're testing, is bone versus air conduction. So those are the two tuning fork tests for the ear. Again, you need to know what they are, but we're not going to perform them on our head-to-toe exam. All right, so we've done cranial nerve 8. What's the next one? Cranial nerves 9 and 10, glossopharyngeal and vagus. We're going to do these both at the same time. It's nice if you can have a light source so you can see in to their throat. And you're going to say, open your mouth, stick out your tongue, and say ah. Okay, so what we're looking for is the tongue to be midline. And as she says ah, her soft palate and uvula should raise up again in midline. If they raise up off to one side, that would be considered abnormal. So cranial nerves 9 and 10. Then we're going to do cranial nerve 11, the spinal accessory nerve. This is we do this the exact same way we did the neck and the shoulders for the musculoskeletal exam. So I want you to push against my hand, against this side, push forward, pull back, and shrug your shoulders. All right. So those are the spinal accessory nerves. Then we have cranial nerve number 12, which is hypoglossal. So say light, tight, and dynamite.
Light, tight, and dynamite.
All right, so cranial nerves 1 through 12. When you do them all together, it shouldn't take a very long time. All right, and then we have sensory exam. Sensory exam, the principles, remember, we do the hands and we do the feet, and if they're normal, we assume everything else is normal. What's the first thing we're going to do for sensory? We're actually going to start with light touch. So you can use your Q-tip that you use for the trigeminal nerve. And why don't you just put your hands on your lap and close your eyes, and I want you to tell me where you feel a touch.
Pinky. Other pinky.
Which thumb?
Left.
Okay.
Right thumb. Middle. And middle.
Okay. And then on the feet, you're typically going to do the big toe and then a smaller toe. So.
Big toe, right. Right little toe. Right left toe. Big toe.
Okay, so that is light touch or gross touch. Because it's such the feet, throw it away. Next we have sharp or dull, pain sensation. So there's a couple different ways you can do it. You can use a clothespin, or if you have one of these type of reflex hammers, they have a little pin in them. So you can use the pin to touch their skin. If it punctures the skin, you should either throw it away and get a new one, or you should put it through the autoclave. So whatever your sharp object is should not be so sharp that it draws skin. If it does draw blood. If it does draw blood, you should throw it away. So what we're going to do is have her put her hands on her lap again and close your eyes. Now, this is dull
Okay.
and this is sharp. So I want you to tell me if it's either sharp or dull. All right?
Dull. Sharp. Sharp. Dull. 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 Sharp.
Okay. So notice we didn't do the same sequence every time, but you change it up. Then again on the feet, sharp or dull. All right, so you do both feet, and then you're done with sharp or dull, pain sensation. All right, what's the next part of sensation that we're going to do?
We're not doing temperature.
We're going to skip temperature. So now we're going to test the posterior columns. So in order to do that, we're going to do position sense, vibration, and one more. What's okay? Tactile discrimination. All right. So for position, what you're going to do is again isolate the joint that you're going to work on. So if I'm going to work on this first finger, you're going to make sure the other fingers are out of the way. If the fingers are like this, as you do the test, it can bump into her other fingers, and that'll tell her what direction it is. So isolate the finger, and it's only this very first joint. So you're going to move the hand up and then down. And so this is going to be up. This will be down.
Okay.
All right, so close your eyes.
Up, down, down,
Okay. And so again, you want to do the first.
down, up,
Okay.
up,
The first, the second, and the fourth digit,
up, down, down.
which would be your index finger, your middle finger, and your pinky. Do it both hands, and you can also do it to the feet, although it's usually done just to the hands. So that's position sense, also called proprioception. Then we're going to use another tuning fork. This one should be a 256 or a 128 hertz, and you're going to hit it so that it vibrates. And now you're going to put it on top of her joint while you put your hand underneath. So, what do you feel?
Vibration,
Okay, what do you feel?
vibration,
All right.
vibration, vibration.
Okay. Why do you put your hand underneath?
Stable,
If you can feel the vibration through her finger, she should definitely be able to feel it. The other thing you can do is as you're going through this test, you can kind of like dampen it and test if she's just saying vibration, vibration, vibration. So you can test to see if your patient might just be telling you what you want to hear. Does that make sense? You can also do it to the feet. So that's vibration sense. Then the last one is tactile discrimination. We have 5 techniques. You're going to choose 2 to do for your head-to-toe exam. So the first one is stereognosis. So we're going to reach into our bag of tricks and pull out an object. Please close your eyes. Hold out your hand and you'll get a surprise. What is that object?
button.
Okay. So the recognition of an object by feel is called stereognosis. Next, what we can do is we can ask the patient to close their eyes and hold out their hand. And we'll hold the hand facing them. And you want to make sure that you draw facing up for them. Don't draw upside down letters. So you're going to draw a letter on their hand. This is a T. Now, what letter is this?
S,
Okay, and what letter is this?
O,
O. So that's called graphesthesia, the ability to feel a letter that's being written on the hand. So the rules for that: hold the hand facing them, draw the letters facing them, and upside up for them. Sometimes you'll see people doing it like this, and they'll be drawing letters facing the examiner. That's no good. You got to draw it facing the patient. All right. So those are the first 2 techniques. Then we have 2-point discrimination. So for 2-point discrimination, we'll take a clothespin or a paper clip and unbend it. And what we'll do is on the back of their hand, we'll measure. We'll say, is this 2? This is 2, and this is 1. All right. So close your eyes. Did I touch you with 1 or 2?
1, 2, 1. I don't know. 2, 1, 2, 2. 1.
Okay, so you get closer and closer together. Eventually, she won't be able to tell that there's 2, and you measure that distance. That's the 2-point discrimination. Then we have extinction. Close your eyes. I'm going to touch you in 2 spots, and I want you to tell me both of those spots.
Leg and arm.
Okay. So what you're thinking right now is, well, anyone can do that. That's not hard. Well, it's because you don't have neurological dysfunction. So in a person with neurological dysfunction, sometimes touching two places at the same time, one will mask the other and they'll only feel one. Then the last one is point location. So close your eyes and I want you to point to where you feel a touch. So that's point location. All right, so those are the 5. You get to choose which 2 you want to do. So that's sensation. Next we have muscle or motor function. So first thing is inspection of muscles and then strength testing. Now, yesterday we learned kind of a more involved strength testing. Today we're going to do a more concise strength testing. This is the one you're going to have to do for your final exam. So what you have to do is push forward, pull back, push to the side, to the other side, shrug your shoulders, push out, hold your arms out, don't let me push down, don't let me push up, don't let me push out, and in. Good. Now, bring your arms like this, don't let me pull out, don't let me pull out. There you go. Now, don't let me push in. Good. All right, and I want you to squeeze my fingers. Good. All right, now, lift up on your leg, and the other one. Good. Push out, and in. Push out, pull in, push out, pull in, push up, and push down. All right, so that's going to be your shortened strength exam. So each of the same body parts that we tested yesterday, but just much quicker fashion. So that's the first part of the motor exam. Then we're going to do deep tendon reflexes. For deep tendon reflexes, there's a couple of different tools you can use. This is the traditional hammer, reflex hammer. It has a specific name. I can never remember what it's called anymore, and you don't have to know either. There's this kind, which is a fancier version of the same one. These I've only been able to find from drug reps, so snag one from a drug rep. They're a little bit heftier. They've got a nice weight to them. These are my favorite ones for whacking patients. You also have this one, which is circular, and this circle can flex to the side, so you can kind of pendulum it like this, or you can hit like a traditional hammer. And it also telescopes to give you more whack. The other end is a little bit sharp, so you can do sharp or dull with this side, and you could also do your graphesthesia with it. And then we have this hammer, which is a little bit smaller. It's got a little more pointy ends to it. It has the sharp needle on the one side, and then the other side unscrews and has a brush for doing either the dull or the gross sensation. So these are a couple of different tools you can use, but this is my favorite one here. Now the rule for doing these, there's 5 of them, and the first one is actually the hardest one to do. Well, actually, sorry, the first one is the brachioradialis. So what you're going to do is, it's right along this part of the arm right here. And there's a couple different ways that we can try and hit it. So the first one is to have the patient relax with their hand on their lap. And you're going to hit, and the hand should do like this and slightly like this. So you're looking for supination and a little bit of flexion of the wrist. The other way we can do it is hold their thumb up, let your arm be heavy, and hit right here. And notice how our hand did that? That's what we're looking for. Can be a little bit painful, so don't hit too hard. The next one is the brachioradialis. For the the biceps tendon. For the biceps tendon, you're going to have them bend their arm, and you're going to have them cradle their arm here. Relax your arm, make it really heavy. Now, put your thumb on the biceps tendon, and you hit your own thumb. It's a little painful, but notice how her arm contracted. See that? That's what we're looking for. The next one is the triceps tendon. What you're going to do is you're going to make a V with your thumb and your hand, and you're going to let her arm rest in that and make it heavy. Make it heavy. Relax. There you go. And then you're going to use the flat part and hit this way, and you should see the arm move out like this. So, okay. Let's do it from the other side too, so the camera can see it now. All right, so make the V with your hand. Make sure that you're away so that you're not in the way of the test, and you hit just above the elbow. All right. Next we have the patellar. So find the patella And then as the patella narrows down to a point, just below that point is the patellar tendon. So you're not hitting on the patella, you're hitting below the patella. Again, stand to the side. It's difficult to assess them like this because you don't have enough strength in your whack, but also if they do have strong reflexes, you're going to get kicked. So stand to the side. Patient is hyper-reflexive. All right, so I'll do a little. Now, some patients have very easy reflexes, others are very difficult. Now, imagine for a moment that our patient was one of those difficult cases. What we can do is we can use distraction to try and elicit the reflex. Remember we said someone who's contracted or tense, you won't be able to get a good reflex because the muscle's already contracted. So to distract the person, what you do is have them hold their hands like this and pull. So now they're contracting the muscles along their back. It distracts them from that. All right, the last one is the Achilles tendon. And to do this one, what you're going to do is you're going to reach up under their foot and pull their foot upwards. But relax. Let me pull it up. Okay. And then you're going to hit the Achilles tendon, and you should feel the foot flex a little bit. Again, let me do it. And so it's, you know, a lot of people it's a little bit subtle. It's not like they're going to go straight down. All right, so those are the deep tendon reflexes. What are the 5? Brachioradialis, biceps, triceps, patella, and Achilles. All right, we are almost done with our exam. What's the last thing we have left? Cerebellar function, and the 2 cerebellar functions are balance and coordination. So the 3 coordination tests that you can do, we're only going to have to do 1, but you get to choose. The first one you can do is rapid alternating movements. So I want you to put your hands down like this, and then turn your hands over. Keep doing that. Go faster, 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 faster. All right, so rapid and alternating movement. You could also have them do finger to thumb. Okay. Another test you can do is I want you to take your heel and put it on your knee, and then run your heel down your shin without looking. All right, so heel to, we call it shin to, heel to shin. That's the test. Then the last one is finger to nose. So what I want you to do, you stand right in front of the patient, look me in the eye. So you don't want to let them look at your finger. You want them to look you in the eye. So look me in the eye. And I want you to do is touch my finger, and then touch your nose. Touch my finger, and then the nose. Finger and nose. Good. Now close your eyes and keep doing it. All right, so Stephanie is not drunk today. Or at least enough. All right. Where is it? All right, so that's the finger to nose. Those are the 3 cerebellar function tests that we can do for coordination. Now we're going to do balance. So go ahead and stand up, please. And the first thing I want you to do is I want you to close your eyes and hold your arms out. All right, now I want you to stay balanced. All right, so if she started swaying and fell, go ahead and start. That would be called a positive Romberg. As long as she's staying in place, that's called a negative Romberg. All right, the last thing we're going to do is we're going to ask the patient to walk. So just turn around and just take a couple normal steps. Just go ahead and walk. And turn around and walk on your heels. And turn around and walk on your toes. And then one more time, walk with one foot right in front of the other foot. And that's tandem walking. All right, in addition to this, you can also ask the patient to do a one-legged squat. Would you mind standing on one leg for a moment and squat down a little bit and stand back up? All right, so those are your balance tests.